Hello everyone, welcome to today's live broadcast, a keynote presentation, What's New in the News with Prostate Cancer 2015. I am Judy O'Rourke of LabRoots and I'll be your moderator for today's event. We are delighted to bring you this educational web seminar presented by LabRoots. We have a few important announcements before we begin. This presentation has been approved for continuing education credits. If you want to obtain the credits, please click on the Get Your Free CME CE Credits button located in the lower left of your screen. This will take you to the continuing education page where you can select a speaker, click on the CE CME button, and it will take you through the process to obtain your certification. This webcast is designed to be interactive, and we encourage you to ask questions during the event. You can submit questions by typing them in the Q&A box, which can be found by clicking on the green Q&A button at the lower left of the presentation window. We'll try to get to as many as we can, and we'll follow up if we don't have time today. You can enlarge the slide window by clicking on the screen icon in the lower right-hand corner of the slide window. If you have any technical problems viewing or hearing this presentation, please click on the support button at the top right of your presentation window or submit your problem through the green Q&A button lower left. I would now like to introduce today's speaker. Judd W. Moul, MD, is the James H. Siemens Professor of Surgery, Division of Urologic Surgery, and Director of the Duke Prostate Center, Duke Cancer Institute at Duke University Medical Center. Prior to joining Duke, he was a professor of surgery at the Uniformed Services University of the Health Sciences in Bethesda, Maryland, and an attending urologic oncologist at the Walter Reed Army Medical Center in Washington, D.C. In addition, he was director of the Center for Prostate Disease Research, a Congress-mandated research program of the Department of Defense. In 2004, he completed a 26-year U.S. Army career, retiring as a full colonel in the medical corps and became chief of the Division of Urologic Surgery at Duke. Serving as chief from 2004 to 2011, he brought innovation and growth to the program. Most notably, he started the Duke Prostate Center, expanded the urology residency training program through a novel collaboration with the Department of Defense, and was able to maintain Duke Urology as a top 10 program in the nation throughout his tenure. To learn more about Dr. Moul, click on the still image in the right corner for more information or go to the LabRoots site. I will now turn it over to Dr. Moul for his presentation.
Thank you very much. It's really a pleasure and honor to be with you this morning. And LabRoots has put together a really nice cancer program today on various aspects of prostate cancer, and a number of my friends and research associates and clinical associates are part of the program today. So again, welcome. And I'm going to do a little bit of an overview, kind of a smorgasbord on some of the things that are hot and in the news with prostate cancer. And I'd like to bring greetings to everyone tuning in this morning. I know it's fairly early on the West Coast, but we appreciate people logging in and joining us. So I bring greetings from the Duke Prostate Center and Duke University here in Durham, North Carolina. And what we're going to cover today is three issues. We're going to spend some time on the screening debate. That's a really hot topic. We're going to spend some slides on localized prostate cancer and then a little bit on advanced prostate cancer. And obviously, we're just going to be able to cover the highlights and some of the new things that are going on in prostate cancer. The first, with regard to prostate screening with PSA, let's start with an audience polling question. And I'd just like to gauge the audience about your opinion about prostate cancer screening. So the first question, do you believe that prostate cancer is an old man's disease and no man should generally be screened for prostate cancer? Do you generally feel that all men should consider PSA testing to determine their risk and future risk of prostate cancer? Do you feel that only men with higher risk factors, such as African American ethnicity or family history, should generally be screened? Or do you feel that men between 55 and 69 years old should consider prostate cancer screening using PSA? So I just asked those joining us this morning to pick your most appropriate answer and what you believe and submit that. And then we'll have the answers here in just a minute. I will say that while we're waiting for the answers to come in, that the U.S. Preventative Services Task Force is against PSA screening, and we'll talk about that in a minute. However, we're going to talk about the American Urological Association's best practice guideline. So let's see if we can see the answers for the poll. Very interesting. So fortunately, and I'm glad to see that really no one on the line thinks that prostate cancer is an old man's disease and no one should be screened. I think that certainly, I'm pleased to see that. 41.7% of the audience thinks that pretty much all men should have a PSA test, and I would tend to agree with that. I personally believe that a baseline PSA at about age 40 or 45 is really useful to determine a man's future risk of prostate cancer. 12% of the audience thinks that just men with high-risk features should be screened. And then 45.8% think that men between 55 and 69 should be tested generally. And answer number 4 is the guideline from the American Urological Association. So let's move on then. And you see a headline here that talks about the U.S. Preventative Services Task Force. That's a government agency that gave PSA testing a D rating a couple of years ago. And this headline from the Journal of the American Medical Association basically says that this agency finds little evidence to support advising PSA screening in any man. And why did this agency come to this conclusion? We certainly know that the effectiveness of prostate cancer screening, many questions remain. And let's go over that just a little bit. Well, the reason the U.S. Preventative Services Task Force came to that conclusion was primarily because the 2 major prostate cancer PSA randomized trials found conflicting results. One trial found that the rates of, or the death rates from prostate cancer did not differ significantly between men who were randomized to screening versus randomized to just routine care without PSA. And the other trial done in Europe basically found that the death rate from prostate cancer was reduced 20% in the men who were randomized to PSA screening. So we have these 2 conflicting studies. Looking at it a little bit further, the American study was called PLCO, that stands for prostate, lung, colorectal, and ovarian, and they found no mortality benefit for men who got a PSA test. So because it was an American study and because the U.S. Preventative Services Task Force is an American agency, basically they said, look, you know, we kind of go with the PLCO, no benefit, let's not recommend PSA testing. Now, the PLCO study enrolled 76,000 men. The European study that showed a benefit to PSA testing enrolled 182,000 men. The American study used a PSA cut point or threshold of 4.0 to recommend a prostate biopsy, whereas the European study used a threshold of PSA of 3. 50% of the men who had a positive screen were biopsied in the American study. So about half of the men who actually had an abnormal PSA actually went through with a prostate biopsy. And on the other hand, 85% of the European men who had an abnormal screening PSA had biopsy. The biggest challenge of the American study was PSA contamination in 52% versus only 20% in the European study. Now, I'm going to talk a little bit further about PSA contamination. The definition of PSA contamination is PSA testing performed in the control group during or before entering the trial. And this was common. PSA was tested frequently in the control group in the American study. 40% of men in the first year who were randomized to no PSA testing had a PSA test outside the study, and over the 6 years of the study, more than half of the men actually had a PSA outside of the study. And 44% of men in each group had undergone prior PSA testing prior to entering the study. And so right off the bat, that's a huge issue when you're trying to show that PSA made a difference, if there was huge contamination in the control group. And many experts believe that that was a fatal flaw of the PLCO, and the U.S. Preventative Services Task Force should have taken that into more consideration when they went against the PSA test. So again, this heavily contaminated group who had testing on PSA outside the study boundaries. Now, the American Urological Association, and I'm a urologist and I'm a member of the American Urological Association, and I tend to agree with the guidelines that are from my own professional organization. Now, granted, there are other guidelines on PSA testing, and not all of them agree. We certainly don't have time to go through all the different guidelines, but let's just talk a little bit about the PSA guidelines that were released about a year ago. The AUA looked at age groups. They felt that it's important to recognize that we probably need to look at this issue differently. So they looked at men less than 40, 40 to 54, 55 to 69, and 70 plus to ask the question, should we use PSA testing? So I'll just give the overall highlights. In men less than 40, the panel generally recommends against PSA testing, against routine PSA testing, because the prevalence of prostate cancer is so low below age 40. And so the feeling was that you probably may do potentially more harm than benefit in men under 40. And I generally agree with that we really have no business doing PSA testing under age 40 for the vast majority of patients. Now, what about between 40 and 54? Here, the American Urological Association generally is against routine screening for prostate cancer. Now, in men who have risk factors, such as a family history of prostate cancer, or those men who are of African American ethnicity, there may be rationale for doing PSA testing. And some experts, including myself, generally think that obtaining one baseline PSA value at about age 40 to 45 is beneficial to help determine the patient's future risk of prostate cancer. But if we follow the AUA guidelines, in general, we should not offer routine PSA testing to average risk men between 40 and 54. Now, for men younger than age 55 who are higher than average risk, such as, again, family history, such as African American ethnicity, such as men who may have had a baseline PSA at 40 that was a little bit higher than what we would expect. Those men fall into a higher risk group, and I think you need to take an individualized approach and perhaps offer PSA testing selectively. The group that the AUA feels is most likely to benefit from PSA screening is the age group 55 and 6 to 69. And in this category of age, 55 to 69, the AUA generally is in favor of PSA testing, although we strongly feel that the patient should have shared decision-making, where the doctor and healthcare professionals talk about the pros and cons of PSA testing, but to generally offer the test after a patient has been informed of the risk versus the benefit. Above age 70, the American Urological Association generally recommends against routine PSA testing, although we also think we should take an individualized stance. There certainly are individuals at 70 plus who have a long life expectancy, and it may be appropriate to continue periodic testing in men older than 70 in selected situations. Now, let me switch gears and talk a little bit about prostate cancer medications. that might affect PSA. You see this headline, the drug's ability to decrease prostate cancer risk is confirmed. There are a number of medications that are important that we at least talk a little bit about. One is finasteride. Finasteride is a drug that's been FDA approved for many years, and it's now available as a generic medication that is FDA approved to treat benign prostatic hyperplasia. It also causes generally a 50% reduction in PSA levels, and we know that men who are on long-term finasteride have a 25% decreased risk of developing prostate cancer, although finasteride is not officially FDA approved for chemo prevention. Recently, long-term safety data has been released on finasteride showing that it does not cause lethal high-grade prostate cancer. Now, there was some early concern that finasteride might lead to high-grade prostate cancer, but long-term follow-up confirms that there was no excess death rates in men who were treated with finasteride for many years. So I believe finasteride is a very safe drug. I want to mention the SELECT trial, which was a National Cancer Institute large trial, and the key teaching point is that vitamin E and selenium do not prevent prostate cancer. Furthermore, vitamin E and even perhaps selenium supplementation actually might increase the risk of prostate cancer slightly. So the key teaching point, I would not prescribe vitamin E or selenium to try to prevent prostate cancer. Dutasteride is also an FDA-approved agent to treat benign prostatic hyperplasia in the same class as finasteride. And similarly, the REDUCE trial showed a 23% reduction in prostate cancer with no increased risk of high-grade cancer. And this drug also will decrease PSA by about 50%. So in practice, it's important for all physicians and healthcare providers to have a little working knowledge of finasteride, SELECT trial, and dutasteride. This is what I alluded to earlier on finasteride, no difference in long-term survival with finasteride or placebo in prostate cancer prevention trial, basically proving that finasteride is safe with very long-term follow-up. Now, let me switch gears to localized prostate cancer, and we'll spend a little time on this topic. And basically, this is a gentleman who is diagnosed with prostate cancer, but we believe that the cancer is clinically contained inside the prostate, so the patient becomes eligible for localized treatment, surgery, radiation therapy, cryotherapy, and let's spend a little bit of time with that. Let's do an audience polling question. And I want you to answer the true statement, and I'll read them. Patients with Gleason 7 are best candidates for active surveillance. Is that true or false? For men less than 65 years old, middle grade patients, such as Gleason 7, randomized to radical prostatectomy had improved long-term survival versus watchful waiting. Number 3, randomized trials have proven that external radiation is equivalent to radical prostatectomy. And 4, molecular diagnostic risk assessment of prostate biopsy tissue has proven benefit in prospective randomized trials. Which one of those statements is true? While we're waiting for the answers, I just want to mention that Gleason 7 would be considered middle grade prostate cancer. This is middle grade or intermediate grade prostate cancer. Gleason 6 would be low grade. Gleason 7 would be intermediate grade. And Gleason 8, 9, or 10 are high grade prostate cancer. So that might help you answering that question. So let's go ahead and see what our answers are. Let's see if we've given enough time. So the poll is closed. So the correct answer is actually B. For men less than 65 years old, middle grade patients randomized to radical prostatectomy had improved long-term survival versus watchful waiting. So that was the correct answer. The majority of the audience answered D. Now I'm going to talk about molecular diagnostics, and I'm a big fan of using molecular diagnostics, and there have been some excellent trials done. However, there have been no formal prospective randomized trials done. Not necessarily that we need those, but I guess maybe this was a trick question. There have been no prospective randomized trials formally in that setting showing that molecular diagnostics for a prostate biopsy tissue is proven beneficial. But we'll talk about all four of these. Now, let's move on to the next slide. Close our polling there. Let's say a few words about active surveillance. So what is active surveillance? Active surveillance is taking a gentleman who has generally low-grade, low-stage prostate cancer and not actively treating him, not doing surgery, not doing radiation, but simply following him, seeing him back periodically for repeat lab testing, physical exams such as a rectal exam, and perhaps molecular testing, and only treating him should his cancer progress. The National Comprehensive Cancer Network in 2012 basically proclaimed that active surveillance should be the only treatment option for very low-risk men who have, and men with low-risk prostate cancer who have an estimated less than 10-year life expectancy. And I will say that active surveillance is growing in popularity. Now, a really awesome paper was just published by Laurie Klotz and colleagues from Toronto. Dr. Klotz and their team in Toronto, I think, have the longest running series of active surveillance, and they've recently published their follow-up, and it's quite interesting. So it's called Long-Term Follow-up of a Large Active Surveillance Cohort of Patients with Prostate Cancer. And I'll just give you the executive summary. The 10 and 15-year actuarial prostate cancer-specific survival was 98.1% and 94.3%. So the long-term survival of these patients was excellent. At 5, 10, 15, and 20 years, 75, 63, 55, and 55% of patients remained untreated on active surveillance. So I think these are good numbers to counsel patients as to what their likelihood of remaining on active surveillance based on the Toronto series. Metastatic prostate cancer developed in 2.8% of men at a median time of almost 10 years after diagnosis, and 1.5% of men died of prostate cancer. Of the 28 men developing metastasis, 44% were Gleason 7. So what this tells us is that the middle grade cancers of Gleason 7 seem to be the ones that are potentially at risk of developing metastasis and dying of prostate cancer, and kind of tells me that, gosh, we really need to pause and think, especially if it's a younger man in good health, before we offer or routinely do active surveillance on the majority of men who have Gleason 7 middle grade cancer, especially if it's higher volume cancer. The overall survival rates were 80% at 10 years and 62% at 15 years, telling us that, again, selecting perhaps older men and men with low-grade prostate cancer who have a significant chance of dying of other causes before their prostate cancer progresses makes sense. And the ratio of deaths from non-prostate cancer to prostate cancer was 9 to 2.1. So in other words, in a properly selected group of men, older men with low risk, low grade prostate cancer, most of the men are going to die of other causes and not prostate cancer. And then this ratio is 9 to 2.1. What are the reasons for intervention? In other words, when do you switch gears? You got a guy on active surveillance and you're following him. When is it time to change course? Well, in the Klotz study, they used a PSA doubling time of less than 3 years. They also used MRI later on in the series, and that's growing in popularity, although it remains controversial. Intervention occurred in 45.5% of men due to short PSA doubling time. So basically, almost half the men switched gears from active surveillance to active treatment because of their PSA going up at a fairly robust rate, short PSA doubling time. 3, increase in histologic grade on subsequent biopsy led to treatment in about a third of the patients. So again, these gentlemen typically have repeat biopsies every 1 to 3 or 4 years, depending on the age and health of the individual. And a third of the times that treatment was, they moved from active surveillance to active treatment was because of biopsy Gleason change or grade change. 4, clinical progression such as developing a palpable nodule on the digital rectal exam confirmed as cancer was also an indicator of treatment, but we don't know exactly, can't tell exactly how often that occurred, but urologists typically will do or should do a rectal exam on their follow-up visits with active surveillance patients, and if you feel a nodule or feel a change, you probably repeat the biopsy or move on to treatment, especially if it's a younger, healthier man. And patient preference. So sometimes patients just get tired of active surveillance, and that occurred in 6%. So it's a very important study on active surveillance. Let's switch gears and talk about surgery versus watchful waiting. And in March of 2014, long-term follow-up of the Bill-Axelson Scandinavian trial came out. In fact, this was the third published update with 23 years of follow-up. I mean, long-term follow-up in a group of men from Scandinavia who years ago were randomized to surgical removal of the prostate versus watchful waiting. And now that we have this incredible long follow-up, we've learned a lot from this study. This just shows the blue being death from prostate cancer in all patients, with the left side of the screen showing, let me just go show this here. This is the left side of the screen, and what you can see here is this is in all patients who underwent radical prostatectomy. The blue is death from prostate cancer, and if we look at this other side, this is watchful waiting, and again you can see that the blue here, the death from prostate cancer, was higher for all patients. Now, if we look at men less than age 75, we see here the radical prostatectomy patients versus the watchful waiting patients. We look here at the deaths in blue, and we look at the deaths in blue. So much more pronounced in men less than age 65, showing a benefit in favor of surgery. Again, this was the correct answer on the audience response question a little bit earlier. So again, key teaching point for younger men. Speaking of key teaching points, these are some of the overall key points from this particular study. Over 85% of patients in this trial had palpable disease. In other words, this study was done prior to the advent of PSA, so most of these cancers were diagnosed based on a positive digital rectal exam. So it was a pre-PSA era enrolled study. Radical prostatectomy was superior to watchful waiting for intermediate risk prostate cancer for most men. Healthy young men less than 65, even with low risk, especially if the cancer was palpable and they could feel a nodule, should consider surgery or active treatment. But it's still unclear if and how to use this information for a man with low volume, non-palpable Gleason 6 low PSA prostate cancer. In other words, this really doesn't necessarily say that surgery is better than modern era active surveillance that was practiced in the Klotz trial. But what I would say, and what my take as a clinician is, younger men, less than 65, who are on active surveillance should probably move on to surgery or active treatment if they develop a palpable, progressive, lower intermediate risk prostate cancer. Meaning if it's a young guy on active surveillance and he develops a nodule on his prostate, and you biopsy it, and that is confirmed as prostate cancer. That's palpable disease. He's still young. If you believe this Bill-Axelson paper, it's probably time for him to move on to active treatment. Not everyone agrees with that, but again, that was my practical take-home message. Let me switch gears again and talk just a little bit about genetic tests in prostate cancer, or molecular markers. And you see the headline: 2 new genetic tests offer personalized medicine for newly diagnosed prostate cancer. And this is a picture of my good friend Peter Carroll from University of California, San Francisco, who's been a leader in this area. And let's just show you a little bit of the waterfront on these molecular markers. And this slide just shows a menu of some of the things that are available. Prostate Health Index is a blood test offered by Beckman Coulter that is FDA approved. It's similar to PSA. It's a secondary screening blood test that would give more information than a PSA test. The 4K score is another blood test offered by Opco Labs, also provides more granular information than PSA and may help in decision making. PCA3 is a molecular urine test done after a prostate massage, where the gentleman gives a urine sample directly after the urologist does a prostate massage. Also useful as a secondary test, is FDA approved to be used after a negative biopsy on a man who still has an elevated PSA. You can use PCA3 again after a negative biopsy. Confirm MDX is a tissue marker based on methylation that can be done on a negative prostate biopsy to give the urologist an indication if he had missed important cancer on the biopsy. This is a busy slide that compares the PI blood test to the 4H score to the Prosterics versus PCA3. I just boxed one aspect of the 4K score, that this blood test can help predict the probability of intermediate or higher grade prostate cancer. And so even though these tests are still somewhat in their infancy and just starting to be employed in practices, this is one blood test that could be used in the future to help guide decisions regarding active treatment versus active surveillance. If you had an elevated 4K score suggesting a reasonable risk of higher grade cancer, yet the biopsy only showed Gleason 6, this could be a subtle indicator to rebiopsy or move on to active treatment. And then after a negative biopsy, again, PCA3 is the molecular urine test, which is FDA approved in this setting. Again, a urine test done after a prostate massage, urine collected after the digital rectal exam. Confirm MDX is done on the biopsy tissue, looking at methylation changes, and gives an indication whether important cancer may still be lurking in the prostate that may have been missed on the initial biopsy. And then once a gentleman has had a positive biopsy for cancer, once you know that there is prostate cancer and you're trying to make a decision between active treatment and active surveillance, the 2 most common commercially available tissue markers are the Prolaris test offered by Myriad Corporation and the Oncotype DX test offered by Genomic Health. We also use the Decipher test and Prolaris that can be done on tissue after a radical prostatectomy. And on this one slide, I'm just going to briefly provide a comparison between Myriad Prolaris and Genomic Health GPS. Both of these are performed on archival paraffin-embedded tissue from a prostate biopsy and measure RNA expression profiles in that archival prostate cancer tissue. The Myriad Prolaris focuses on cell cycle progression genes, 31 genes in the active group and 15 housekeeper genes. It provides a risk score, and the test primarily predicts prostate cancer disease-specific survival and PSA recurrence, or biochemical recurrence. It can be done on biopsy tissue. It's also commercially available for radical prostatectomy tissue, and as of recently in 2015, does have reimbursement coverage for Medicare patients. The Genomic Health GPS is also an RNA expression panel of multiple cellular pathways. It has 12 active genes and 5 housekeeper genes. There's also a risk score, which is 0 to 100. The genomic health test is used only on biopsy tissue, and it's only approved for use on Gleason 6s and low-volume Gleason 3 plus 4 equals 7. It predicts adverse pathology. In other words, it gives you a probability, if that patient undergoes radical prostatectomy, what the likelihood is of that patient having higher grade cancer or higher stage cancer. And both of these, and also has Medicare coverage as of 2015, both of these tests are designed to help doctors and patients make better decisions as whether they're going to do active surveillance or active treatment. Both tests have a fairly robust literature, a lot of literature out on both tests that's been published, but the answer to the question, neither of these tests have been truly validated in a prospective randomized controlled trial yet. They do have Medicare coverage. They're becoming more widely accepted. We'd still like to see some more prospective data and longer-term follow-up, obviously, on both of them. I want to spend just one or two slides on prostate MRI. Growing in popularity, and the key teaching point is over the last several years, the MRI imaging technology has improved to the point where many experts believe that MRI can help better identify prostate tumors inside the prostate. But there are still limitations. The MRI does not see all tumors. MRI increases the likelihood of finding a Gleason 7 or intermediate risk tumor, but really still can't tell you if that tumor needs to be treated. And MRI has no long-term follow-up data in the active surveillance population. So we really are still struggling and learning how and when to use MRI in a patient that we have on active surveillance. As far as prostate biopsy, whether it's the first biopsy or a subsequent biopsy, in 2015, there are really two ways that urologists will do prostate biopsy. The Transrectal Ultrasound guided prostate biopsy, or TRUS biopsy, or the MRI-Directed Biopsy. The TRUS biopsy has the advantage of being widely available. It's efficient, single visit. It actually detects more cancers than MRI, but it's been criticized for over-detection of Gleason 6 low-grade cancers, especially those that might be picked up in older or elderly individuals. And the ultrasound is felt to be more random than ultrasound because the ultrasound cannot necessarily see these tumors. Nevertheless, remains the gold standard with regard to insurance reimbursement and efficiency. The MRI-directed biopsy is not yet widely available. It generally would require a separate visit for the MRI test, and then the MRI has to be processed, and then it would require a second visit for the transrectal ultrasound. Because what happens is the software is able to fuse or overlay the findings from the MRI on the transrectal ultrasound. And so what's happening is the urologist is using the information from the MRI to better guide his truss biopsy. The second visit, though, for the truss generally takes more time because of the technology involved, although the time is getting a little bit better. And it's important for patients and doctors to recognize that this detects fewer cancers, but you're supposedly selectively picking up only Gleason 7 or important cancers. So patients have to be aware that the MRI may actually do less good of job of picking up all cancers, but it may only pick up the important cancers. And I will just say, stay tuned. This is an emerging area, and I just was able to cover, scratch the surface. The last thing that we're going to cover today briefly is advanced prostate cancer. This would be metastatic, generally metastatic prostate cancer, or even men who have what they call castrate-resistant prostate cancer, which is far advanced prostate cancer after the patient has progressed on hormonal therapy. So let's go into our final audience response question. Oh, no, let's see. Let me get that. Oh, never mind. I don't have the, we're going to get to that in a minute. Excuse me. Let me just set the stage for advanced disease. Hormonal therapy, which we'll call HT, is also called androgen deprivation therapy, or ADT, and this is the mainstay of treatment for advanced prostate cancer, and this has been the treatment since the 1940s. In the early 1940s, it was discovered that a man who underwent an orchiectomy, surgical removal of both testicles, responded beautifully, and many times advanced prostate cancer got better. And then we learned that the reason for that was that testosterone, the male sex hormone, which is produced by the testicles, was the fuel for advanced prostate cancer. So ever since the early 1940s, hormonal therapy has been widely used, initially as orchiectomy, and then for the last 30 years as medical castration or medical hormone therapy in the form of shots or injections and pills. And these shots are either LHRH agonists, such as leuprolide acetate or glycerolin acetate, or GnRH pure antagonist. Current commercially available one is Degarelix. You could also still do an orchiectomy, and some doctors will also add in oral anti-androgen medications for a better hormonal blockade, and that's called complete hormonal therapy. Doctors can use this hormonal therapy intermittently, meaning you basically give patients shots off and on, or continuous, where you just continue the hormone treatment for the rest of the patient's life. For M1, which is metastatic prostate cancer, mostly a patient who would have a positive bone scan or a CAT scan showing distant metastasis, continuous hormone therapy is probably a little more effective, and one now over the last couple of years you're really trying to maintain a low testosterone level less than 20. But we also know that hormone therapy or androgen deprivation therapy has toxicity, increasing the risk of diabetes and potentially increasing the risk of cardiac disease. And so it's a double-edged sword. Some patients with metastatic disease clearly have a better benefit from long-term use, but some other patients with less advanced disease, we're going to try to use the hormonal therapy intermittently to avoid side effects. And then in a far advanced castrate-resistant disease, there are several new novel oral hormonal therapies that are FDA approved. So with that background, let me just spend a couple of slides. Here is an example of a randomized trial, again done by Dr. Klotz, who is the principal author from Canada, where they randomized patients to the GnRH antagonist Degarelix on a monthly basis versus the LHRH agonist leuprolide acetate. And what they found is the biggest difference is in the first month, where with the LHRH agonist, you see a flare phenomenon where the testosterone level surges and then eventually gets down to very low levels by about a month, versus Degarelix, where you get an immediate quick blockade, and that about 90% of patients 90% of patients are castrate testosterone level by day 3. So the key teaching point is if you have a patient with advanced prostate cancer where you're really trying to get quick action, generally Degarelix has become very popular as the drug to start with because of this early quick mechanism of action, and then sometime later on the patient would switch to an LHRH agonist such as leuprolide acetate. This slide just talks about some of the side effects of androgen deprivation therapy and the cardiovascular risk. We know that long-term hormonal therapy increases the risk of obesity, has an effect on serum lipids, increases insulin or decreases insulin sensitivity, can increase blood pressure, increase waist-hip ratio, and has some effect on C-reactive protein. It's a growing recognition that, especially in younger, healthier patients, we really want to balance the risk and benefits of hormonal therapy use. And it's still somewhat controversial regarding cardiovascular disease, whether the androgen deprivation therapy really does increase the risk of cardiovascular disease. But again, the key teaching point, there are a lot of side effects of hormonal therapy, so we really want to balance the risk-benefit before we prescribe hormonal therapy. Now, hot news, chemotherapy in newly diagnosed advanced prostate cancer. This is from ASCO Post. Docetaxel combined with hormone therapy extends survival in advanced prostate cancer. And this is, I would say, in advanced prostate cancer, this has been the biggest news over the last year. First, about a year ago, the chartered trial was released. This was Chris Sweeney, who's a friend of mine. He's a medical oncologist out of the Dana-Farber, principal investigator on this study. They randomized over 700 men with new metastatic prostate cancer. In other words, these would be a guy, say, just walking in off the street, never been treated for prostate cancer, never been diagnosed, and unfortunately had metastatic disease on initial presentation, randomized to arm A, which was hormone therapy plus 6 cycles of docetaxel, versus arm B, which at the time was standard of care, androgen deprivation alone, and they were followed for progression and death. 790 men were enrolled between 2006 and 2012, and on January 16, 2014, with a median follow-up of 29 months, there were 136 deaths in the androgen deprivation arm alone, and 101 deaths in the ADT plus docetaxel chemotherapy arm. And this is the survival curve. Quite striking difference. So androgen deprivation therapy plus docetaxel, 6 cycles, 57.6 months median survival versus 44 months in the hormone therapy alone. And again, you can see that here at median, there's a significant difference here in favor of patients who receive docetaxel. And so this caught, I think, a lot of people off guard in the field. I think people were surprised by these results. Early on, the chartered trial seemed to suggest that there was a bigger benefit in patients who had higher extent of disease. So in patients with high volume metastatic disease, there was a 17-month improvement in median overall survival. In patients with low volume metastatic disease, there was a fairly robust hazard ratio in favor of combined therapy, but the p-value was not yet statistically significant, probably because there were fewer patients who had low volume disease. Nevertheless, pretty striking results. And before I move on, this year at ASCO, the Stampede trial, which basically confirmed these results. So we had chartered, and then we had Stampede. So at ASCO 2014, we had chartered. At ASCO 2015, we had Stampede, which is a British trial, which essentially confirmed the chartered results. And I would say right now at most of our major hospitals around the world, if it's a patient presenting de novo with new metastatic prostate cancer, we are encouraged to talk to the patient about androgen deprivation therapy and encourage those patients to also be seen by a medical oncologist for consideration of docetaxel chemotherapy. The last section here before we open it up for questions is FDA approvals 2010 to 2013 for advanced disease. And these are approvals for castrate-resistant prostate cancer. So I'm going to just very, very briefly cover Sapulous-LT or Provenge, which was approved 2010, cabazitaxel, which is a chemotherapy approved again in 2010. We are not going to have time to cover Xgeva or denosumab, but this is a rank ligand inhibitor given sub-Q to prevent skeletal-related events in advanced prostate cancer. A new oral hormonal therapy, Abiraterone, trade name Zytiga, approved in 2011, and another oral anti-androgen, Enzalutamide or Xtandi, approved in 2012, and then radium-223 or Xofigo, approved in 2013. So we've really had some major advances in castrate-resistant prostate cancer. Now here's our final audience response question. If we can get the, so here's our poll. Which of these is the true statement? Provenge is a novel immunotherapy that lowers PSA levels on average by a factor of 4.5. B, cabazitaxel is a novel radiopharmaceutical agent that does not cause bone marrow suppression. C, abiraterone acetate is best taken with meals. Or D, denosumab 120 milligrams sub-Q monthly is used to prevent skeletal-related events. Which of those four statements is the true statement? I will tell you that Provenge or Sapulous-LT is a very novel immunotherapy, and we use it quite a bit at Duke. Cabazitaxel, again, another agent that we use quite frequently in our prostate center. And obviously, abiraterone acetate is one of the new novel oral agents. Why don't we go ahead and close the polling and see how our audience did on this one? So let's see here. The correct answer is D, denosumab. So a third of the audience got this correct. So denosumab is given 120 milligrams sub-Q monthly and used to prevent skeletal-related events. Provenge is a novel immunotherapy, but it does not lower PSA on average by a factor of 4.5. Cabazitaxel is a chemotherapy, not a radiopharmaceutical. Abiraterone is best taken on an empty stomach. So again, so the correct answer is D. So just a couple of final slides. I know we're getting down to the wire here as far as our allotted time, but cabazitaxel was FDA approved in 2000. Key teaching point, it is a chemotherapy. FDA approved based on the TROPIC trial. It's used post-docetaxel and resulted in a survival benefit, as you see on this slide, for men with castrate-resistant prostate cancer who had progressed after docetaxel. Cabazitaxel is produced by Sanofi Aventis, and it's now fairly widely used in patients with advanced prostate cancer. There are four FDA-approved chemotherapy agents in prostate cancer. Docetaxel, which is now generic, but what trade name was Taxotere, mitoxantrone, estramustine, and cabazitaxel, trade name Jeptana. So again, four FDA-approved chemotherapies for use in advanced prostate cancer. CYP-T or Provenge was FDA approved in 2010. Basically, it's a very novel immune product. It's created individually for a patient. Patient undergoes leukapheresis. As you see here, then the patient has his white cells collected. These are processed and then infused back into the patient. It's done 3 times over about a month. The IMPACT trial, which was the key trial resulting in FDA approval, showed about a 4.1-month median overall survival benefit of Provenge. I would say the most important information, especially for me as a urologist, is based on what we call the quartile data, looking at when patients received Provenge related to their baseline PSA. And the key teaching point is in men who had baseline castrate-resistant prostate cancer but lower PSAs, baseline PSA less than about 22, the survival benefit was 13 months. So again, picking patients properly for this immunotherapy seems to be critical. Immunotherapy tends to work best with patients with minimal tumor burden, and if PSA is a general surrogate for tumor burden, this would suggest that this makes sense related to the mechanism of action of immunotherapy. Abiraterone, the oral agent, is a Lyase inhibitor. It works in the steroidal pathway. It's going to block steroidal conversion here at the hydroxylase and lyase, so it's going to prevent the development of the hormonal agents along the pathway. It would actually drive the steroidal pathway back this direction towards aldosterone production. But the key teaching point is this blockade in the steroidal pathway lowers androgens, and this could be from the testicular source, the adrenal source, or the tumor itself source. So abiraterone is going to be a blocker that's going to work at all the areas of the body to lower androgen levels. Quite remarkable efficacy. This shows time. This is in pre-chemotherapy treated patients, castrate-resistant patients who have not yet received chemotherapy, showing a significant, remarkable improvement in radiographic progression-free survival, overall survival benefit in the latest final overall survival analysis of all patients was 4.4 months. But remember, too, that the control arm here went on to receive other effective treatments after abiraterone. So you have to always put that into context that this agent with 4.4 months, but the control arm moved on to other treatments. MDV-3100, also called enzalutamide, also known as the trade name drug Xtandi, is an androgen signaling inhibitor. It has efficacy demonstrated pre and post chemotherapy. 160 milligrams orally once a day, can be given with or without prednisone. Well-tolerated agent. Again, similar to abiraterone, a very marked improvement in radiographic progression-free survival and a marked improvement in overall survival in the updated overall survival analysis. So both of these agents, abiraterone and enzalutamide, have added widely to our armamentarium for advanced prostate cancer. Obviously, neither of these agents are necessarily home run agents, but the drugs have clearly made a difference and can delay the time to chemotherapy in some patients by more than 2 years. So widely used, widely effective. I wanted to have at least 2 or 3 minutes for questions. Again, I really want to thank you very much for listening in this morning and tuning in. And let's go right into the questions, and we can go ahead and just address these quickly since we do have about 2 minutes left. Do you think, so there's a question from Jeff Ralcio from Covaris Incorporated. Do you think it is possible that in older patients with less than 10-year life expectancy, radiation and chemotherapy can actually shorten their lifespan when compared to active surveillance? In other words, are older patients better off skipping treatment and just enjoying their lives with no worries? Great question, Jeff. Again, I think in some cases that's absolutely true. I think if you if you take it, certainly if you take a patient with low-risk prostate cancer, low Gleason score, low-grade disease, many of those patients are going to be ideal candidates for active surveillance. On the other hand, you know, even if you have an older patient with high-grade metastatic prostate cancer, there's no question that hormonal therapy can have a dramatic palliative benefit as far as bone pain. These new agents, such as Abiraterone and Enzalutamide, can clearly improve quality of life and delay chemotherapy for up to 2 years. So again, I think the key teaching point is taking an individualized approach. Question here from Diego Quinones from Central University. According to Harvard Medical School study, frequent ejaculation helped ward off prostate cancer. What do you think? I think it sounds like a lot of fun. No, seriously, I think there have been studies suggesting that more frequent ejaculation, especially for men between teenage years to the 40s, may show a decreased risk of future prostate cancer. Certainly would make sense, but I think that, again, we're just about out of time. I'm going to turn the podium over to our moderator.
Thank you, Dr. Moul. Just a reminder, if you wish to obtain the credits for today's session, please click on the Get Your Free CME CE Credits button located in the lower left of your screen and follow the instructions. This will take you to the continuing education page where you can select a speaker, click on the CE CME button, and be guided through the process to obtain your certification. Today's webcast will be available for on-demand viewing through March 30th, 2016. You will receive an email from LabRoots alerting you when this webcast will be available for replay. We invite you to forward that announcement to your colleagues who may have missed today's live event. See you next time. Goodbye.